Hello everybody and welcome to another episode of Acute Medicine Shorts. My name's James Piper, I'm the Clinical Teaching Fellow for Acute Medicine at the Royal Free in London. The topic of today's Acute Medicine Shorts is on IV fluids and their prescription. So just a reminder, Acute Medicine Shorts are brief tutorials on key aspects of acute care and summarise guidance and current best practice. And today's reference text is Intravenous Fluid Therapy in Adults in Hospitals, which is NICE Clinical Guideline CG 174. If you have a topic you'd like covering, please don't hesitate to email me at james.piper@ucl.ac.uk, and please also like, comment or subscribe on YouTube. So one of the basic principles of IV fluid prescription, well, the first important thing is to say that no one size fits all. You will often hear on ward rounds consultants or doctors describing their own sort of fluid regime and applying this to all of their patients. But actually, a NC Pod report in 1999 showed that about 1 in 5 patients may come to harm due to inappropriate prescription. And this might be that we give them too much fluid, so let's say the frail elderly, or too little to those who have fluid loss through sepsis or burns. Interestingly, so when I was a medical student, I wrote a paper on IV fluid prescriptions, and it's amazing still, having written that paper a number of years ago, writing about historical practices, how many of those are still influencing today's prescribing practices, such as the type, rate and volume. And very often people write about sort of 1 salty and 2 sweet. The difficulty is that few clinical trials on this subject are conducted on acute medicine units and in emergency departments. So I want to introduce you to the concept of 5 R's today: resuscitation, routine maintenance, replacement, redistribution and reassessment. It goes without saying, hopefully, that fluid prescriptions require regular review, and certainly I'd encourage you, for those that are progressing towards year 5 and graduation, you simply don't just copy the previous person's prescription, which is an easy thing to do at 3 o'clock in the morning when you're tired. So assessment and monitoring. First of all, where possible, take a history of the patient. Read the medical notes, look at any previous input and output charts. These are often done quite mixed. Some are often very well completed, such as in critical care, where the nursing ratios allow detailed documentation of fluid input and output. Others are poorly completed with notes such as OTT, which means out to toilet, on a fluid balance chart, which is essentially uninterpretable. See if there are any previous limited intake or lost thirst, comorbidity and risk of refeeding, which isn't something we're going to discuss today. Assess a patient for reduced systolic blood pressure, less than 100, tachycardia, cool peripheries, and elevated capillary refill time, elevated respiratory rate and elevated News score. One quirky thing to perhaps do is actually just lift the patient's legs for a few seconds and see if there's a change in blood pressure. So if there's not a need for resuscitation, then, as I was saying earlier, you want to assess these 4 constituent parts here. You want to assess the clinical history, clinically examine your patient, look at certainly for jugular venous pressure, edema, both peripheral and pulmonary, and any evidence of postural hypotension. Look at the clinical monitoring scores, such as the News system, fluid balance charts and weight. Again, this is something that is seen and done very variably in acute medicine, which is rather unfortunate, because we really should be paying much more attention to our patients' weights, especially when it comes to prescribing. Use laboratory assessments such as full blood count, urea, creatinine and electrolytes. So when we are doing our reassessment, then we should be doing an ABCD approach, which is something I've talked about a lot in my tutorials. Focus on the perfusion state. You can also use lactate, pH, urea and creatinine as biochemical markers. It's important to notice, reminded that, as I said at the beginning, we can do more harm than good with these fluids, and certainly patients who are being infused large amounts of saline, certainly there's nothing normal about it, or 0.9% sodium chloride, regularly should have daily use and ease because of the risk of hyperchloremic acidosis. This here shows the flow chart or algorithm for resuscitation. You want to identify cause of the deficit and respond. You want to give a fluid bolus of 500 ml of crystalloid over 15 minutes maximum. You then want to reassess the patient. Does the patient still need fluid resuscitation? If so, you would continue to give and up-titrate fluids up to a maximum of about 2 litres. Certainly, if you haven't given that 2 litres, then you should resuscitate up to that point. Certainly, if you have, you should be rethinking about whether giving your patient more fluid is actually the right answer. These are often patients that will need vasopressor therapy if they are for escalation of care. So routine maintenance, so your initial prescription should be 25 to 30 mils per kilo per day of water and 1 millimole per kilo per day of potassium, sodium and chloride, with approximately 50 to 100 grams per day of glucose to limit starvation ketosis. For obese patients, consider switching to ideal body weight and consider prescribing less, i.e. about 20 to 25 mils per kilo per day for patients who are older, frail, have renal or cardiac impairment, and those who are malnourished and at risk of refeeding syndrome. It's important to note that prescribing more than 2.5 litres over 24 hours does increase the risk of iatrogenic hyponatremia. Consider daytime only prescriptions in those who are well. Certainly if you are continually putting in fluid, you're going to disturb the patient's diurnal variations in needing to go to the toilet. I don't think any of us really want to be made to pee at 3 o'clock in the morning if we don't have to be. When you're reviewing the redistribution, for example, you want to consider about any existing fluid or electrolyte deficit, so dehydration and so on. You want to think about, are there any ongoing losses, so post-AKI polyuria, pancreatic or fistula loss, sweating, dehydration and so on. Are there other redistribution or other complex issues, so edema, sepsis, post-operative fluid retention and malnourishment? So again, you want to make sure that when you're assessing your patient that it's all considered in a balance. This final slide here is to give you a balance of composition of IV fluid. So you'll note that 5% dextrose has no sodium or chloride in, but has about 50 grams of glucose in, or 170 calories. Normal plasma has 135, which is probably closest matched to by Hartmann solution, which is why I'll often find Hartmann solution is commonly used, particularly in theatres of critical care and the emergency department, as it is in theory, most common to the extracellular fluid. And that's the end of this Acute Medicine Short. Don't forget to like, share or subscribe, and of course email me if you have any questions. I look forward to hearing from you.